No, I think the participants are still not in.
Yes, ma'am. We'll start in a minute or two.
No problem. Tell me when to start.
Students are admitted, we can start.
We can start? Okay. All right. So, good afternoon, everybody, and welcome to this second session on radio diagnostics. So, just to quickly recap on what we spoke about last time, I had given you an insight about the overall those specific modalities which come under the purview of radiation safety and under the governance of the Atomic Energy Regulatory Board. And these modalities started from X-ray. Then I spoke about the CT scan, the mammography, OPG and other dental X-rays, and the bone densitometry. The one thing which we also looked at a C-arm and how it's useful for, guiding surgical procedures. The one thing which I said I will speak about in the next class is the cath lab. Okay. The cath lab today, as we all know, is a very, very popular specialty within or a facility within a multi-specialty hospital or a super specialty hospital, right? Since today cardiac procedures like angiography, angioplasties, they have become so popular. So a lot many cath labs today are already existing in every city, in every state. There are too many cath labs today, right? So just to have an idea of how this has overtaken the conventional cardiothoracic surgeries, we'll just have a look at the cath lab setting, and then I can talk a little about it. Yes. So cath labs are nothing but cardiac catheterization laboratories. It's a very specialized facility within a hospital. And the speciality of this cath lab is that it is both diagnostic as well as therapeutic. So when you say diagnostic, it helps to visualize the coronary arteries and identify blocks within the arteries. When you say therapeutic, it is used to open the blocked arteries by doing procedures like angioplasty. We can also do implantation of pacemakers, defibrillators, and so on. So if you look at a cath lab, what essentially does it have? It basically has a fluoroscopy. Okay, this is the same thing which is the C-arm. So it's a fluoroscopy equipment, basically. It also has large monitors, which is the monitoring equipment, which helps us to visualize right? Once we radiologically visualize the coronary arteries, we inject dyes to see how and where the block is and how intense the block is or how severe the block is. Okay, so we get pictures like this where you can see the coronary artery and you can identify blocks in which part of the coronary artery, because the anatomy of the coronary tree is already defined. So you have the right coronary artery, left coronary artery, and all its branches, right? So you can identify the blocks and the extent of the block also by looking at the passage of the contrast dye. The same concept applies, which we had applied to the IVP. If you remember, the X-ray, one of the X-ray techniques, I showed you the pictures of an intravenous pyelography, and also I showed you about the barium meal and the barium swallow. So these are some specialized X-rays, I said. So similarly, this also works under the similar principle of injecting a contrast dye and visualizing the flow of the dye through the coronary artery. Okay, so here it helps us with the coronary angiography, which is a diagnostic procedure. On the other hand, on the right side, I have shown the picture of the coronary angioplasty, which I think most of us already know the procedure. For those who don't still know the procedure, I'm just giving a brief introduction of what we do. So we essentially put in a balloon catheter. See, there is a block. So this yellow thing is an atheromatous plaque. It is a deposition of cholesterol, that is fatty deposition, at the sides of the or the walls of the arteries, which narrows the passage of the blood flow, right? So because of this narrowed flow, person suffers from chest pain, the muscle gets less blood supply to a particular area, and then the patient suffers from chest pain initially and might lead to a myocardial infarction, which is a heart attack, right? So we insert a balloon catheter. This is a balloon catheter. You can see the balloon getting inflated here. Once the balloon inflates, obviously this narrowed passage opens up, right? We push it in and inflate it. So the narrowed passage opens up, and then we put in this mesh kind of a thing, which is a stent, which remains there in situ and keeps the passage patent. So then the flow of blood is comfortable, right? So this is a totally therapeutic procedure which has now overtaken all conventional procedures, and people prefer angioplasties unless and until a coronary artery bypass graft, a CABG, is indicated, which is not going to be the case for all patients. CABG is indicated only when there's very severe stenosis or a triple vessel disease or something like that. But otherwise, most of our patients can be treated using angioplasties. Besides this, for the placement of pacemakers, defibrillators, ICDs, and all of that, we can use the cath lab and the fluoroscopy guidance to do these procedures as well. Okay, so as far as the organization of the cath lab goes, it also involves a similar kind of a setup wherein you have, this is your actual cath lab room where the procedures are being done. And you have a console at the side where these images are being visualized, just like we spoke about. I showed you the console of, I think, the CT. Where did I show you the console? Okay, so next door to this or adjacent to this would be the console of the cath lab, where people can sit and visualize these images, and take the recordings of those so that we can provide it to the patient. Sometimes following an angiography, there is not sometimes, but most times following the angiography, there is a counseling session wherein these images are displayed on the monitor and the patient's relatives are counseled about where the block is, how trivial or severe it is, how critical it is, and how important it is to go in for an angioplasty. And then immediately the patient is posted for an angioplasty. So this is overall the flow in the cath lab. So that is the last modality that deals with X-rays, okay, radiation, and which comes under the purview of AERB. Now, forward, all the other modalities are not radiation emitting modalities. They are radiation-wise very safe, and they use different principles of imaging technology. So the first and the most common in that would be the MRI. So from the name MRI, you can make out magnetic resonance imaging. So this is basically a radiology technique which is using magnetism. So the principle behind MRI is magnetic radio waves. Okay, so it uses magnetism and it uses radio waves. So these are absolutely radiation safe. Okay, they are painless techniques with no X-ray radiation. So that way they are very safe. Okay, there is, if you look at the structure of it, it's got a tube which is surrounded by a circular magnet. And then the patient is placed inside a table. And this is how it looks. Yeah. So again, this is the gantry of the MRI. If you look at the technology part of it, you have these radio frequency coils which are aligned around the patient. They are gradient coils. They are magnetic coils. And this is the scanner. This is the patient table where the patient is slided into the, or in between the gradient coils and the magnet. And then the scanned different images are taken. So this is how it looks. So this is the magnet and this is the bore of the magnet. Okay. So a magnetic field essentially is created at the poles. Okay. So again, just a different kind of a view. So this is a Y coil, this is a Z coil, this is an X coil. So these are all different magnetic coils which are around the patient. So I told you it's got coils, gradient coils, and it's got magnet, it's got a scanner. So these are essentially the parts of the MRI. Now, when do we prefer an MRI scan over a CT scan? Here we are. Here is the console. So this is what I was looking for. So the console is the place where you can view the X-ray the imaging modality happening through this glass window, and you have the images on the screen. So there's generally one person who sits at the console while another person does the procedure inside or assists the patient by giving the position, putting the patient, preparing the patient and putting the patient on the machine. So all this is done by one technologist who is inside. And at the console, you can either have a very senior technician or you can have a radiologist who sits and reports the images. Of course, the images can be saved, so the radiologist can report it at any point in time. Today, for all imaging modalities, we have the PACS system, where radiologists can sit anywhere and report the images and give us the images at any given point in time. Okay, so that has made life very simple for us. We don't have to wait for a radiologist to come on campus and read the images and give it to us. It can go to them on a PACS system software, and then we can get the reports. So these are some points which I wanted to highlight. So the strength of the magnet can be anything from 0.5 to even 3 or 4 Tesla. The higher the Tesla, the lesser noise it makes, the more accuracy it gives, more intricate details can be seen on a higher Tesla machine image. So the clarity is much better. These coils which we spoke about, they are basically immersed in liquid helium. And here we have a really big challenge because this liquid helium recondenses So basically there is a cryo cooler. Okay, this cryo cooler condenses the helium vapor. Helium is a gas, right? So it condenses the helium vapor into liquid helium. And in that liquid helium, the cryostat coils are immersed. So the challenge here is to keep the liquid helium in the liquid state all the time, right? For that, the cryocooler temperature has to be maintained constantly at a very, very low range, which is almost like about -20 and so on. So at that range, we maintain the temperature all the time. Okay, so at any point, if any of the technologists just happens to switch off the cryocooler by mistake, all the liquid is going to evaporate into helium vapor, and it's a big for the organization monetarily also. Okay, so that's one of the points to be remembered. This RF transmission system basically is the one which processes the signals. So the coils, they have a preamplifier, and there are signals which are emitted, which are captured by this RF transmission system, and they are processed. Basically, the signals are processed into images, and there is a computer, of course, a computer processor, which is processing these into images, and then that is the final output that we get. Okay. Now, I was asking you about the indications for an MRI scan, or when we prefer it over a CT scan. Whenever we need very detailed accuracy for a particular disease detection, we prefer to use an MRI scan. So the most important conditions would be related to all kinds of tumors, cancers, trauma, and aneurysms, or problems with the spine, the intervertebral discs, the discs between the spine, the vertebra, any disorders of bones, joints, tendons, ligaments, soft tissues, things that we can't really see very accurately on an X-ray or a CT. Those are the ones which we generally prefer. Today, all over, orthopedicians, spine surgeons would always go in for an MRI as compared to an X-ray or a CT, right? Because these, minute details are far better seen on an MRI. So if you see here, most of it are ortho-related. So the spine, the bones, the joints, the soft tissues, organs, right? And of course, for oncologists also, this is the preferred modality. Okay. So the specializations which require MRI are basically orthopedics, neurology, neurosurgery, oncology, oncosurgery. These are the main specializations which require this. And sometimes maybe, nephrologists and so on. Now, what are the risks with an MRI? People who have metallic implants in them, bone plates, artificial joints, any kind of prosthesis. Prosthesis are implants, right? So any kind of prosthetic device which is implanted in them, which you can't take out. And if somebody's got like maybe a metallic tooth set which you can take out or something, that's no problem. But if you have an implanted prosthetic device in you, it can distort the images. It can interfere with these magnetic radio waves, and it can interfere or it can distort the images. So we don't take such people for MRI scans. We will counsel them and move them towards a CT scan itself. Okay, so that's one thing which we have to note while admitting a patient into the MRI department itself. We have to take the history. There's generally a form which all the MRI departments have, which we ask the patient to fill in before taking up the MRI scan. Right, so this gives us like questions like, whether the patient is, even for CT and X-ray, we do ask patients to fill in the forms, which asks whether the patient is pregnant or not, what was the last day of menstrual cycle, and so on. Here we ask for whether the patient has any metallic implants placed in it, any surgery done in the past, so that you can prevent those patients from taking up an MRI scan. The other risks with this MRI would be allergy to the contrast dye. Now that of course can happen with X-ray also, with CT also. But yeah, that's one of the risk factors. I think I mentioned it in X-ray and CT as well. So many people get allergies to contrast dyes. But if there is a history of an allergy, then at least you can, use a different contrast dye if a person is particularly allergic to any one, specific dye, or if there's something like that. Poor cooperation of the patients may be there because of claustrophobia, especially people who are not very fond of, noise which is very close to your ears. Because, there are, of course, the newer machines are all noiseless MRI machines. They're silent machines with no noise. But yes, there are still older machines which are in the market, which are being used, which can create a lot of noise, and that results in poor cooperation. Plus, if you're doing these scans for smaller children or very old patients, they also can create issues with cooperating for the entire procedure. Okay. Yeah, so we prevent these patients with metallic implants because it distorts the signals. There is artifacts which can come up. So that's something to be remembered. So 2-3 important challenges I have discussed with you. One is the liquid helium, the other is the metallic implants, and the third is the allergy to the contrast dyes. So that was about MRI. The next modality is about the nuclear scan. Okay, so nuclear scan, from the name you can make out that it involves some nuclear radioisotopes. I'm sure we've all studied this at some point in college or school, that there are radioisotopes which are very often used for diagnosis and treatment of diseases, right? So they can be diagnostic nuclear medicine also, and they can be therapeutic nuclear medicine also. The diagnostic part basically describes the organ functions, the structure, okay? And it uses only those radioactive isotopes which are very short-lived. So there's nothing much to worry. It immediately gets excreted from the body. We don't use radioisotopes which live in the body for too long and create some damage. We use very short-lived radioisotopes. This can be easily eliminated from the body. And these doses of these radioisotopes are basically targeted to identify the unhealthy tissue. Okay. Now, in the case of therapeutic, looking at it from a therapeutic standpoint, these radioisotopes, they are attached to certain antibodies, okay, which have a very specific affinity for some cells in the body. So they attach to those antibodies, and these antibodies, they guide these isotopes to the cancer cells where the radioisotope can destroy them. Okay, so this is radioimmunotherapy. So this nuclear medicine, the concept of nuclear medicine, can be very well used in radioimmunotherapy. And this is the mechanism behind it. So these same radioactive isotopes, they are made to attach with antibodies. And those antibodies, they have an affinity for certain cells in the body. So they guide these isotopes to those cells, and then the radioisotopes, they destroy them. All right. So that's about the nuclear medicine. These are the nuclear scan units. See, all of them from a distance might just look the same, but It's just that the concept, the technology behind it is different. Okay. Yeah. Right. Now, the next is a PET scan. Okay. The long form of PET is positron emission tomography. This is also a nuclear medicine technique, and it produces a 3D image, basically. Now, what it does is it identifies the rays which are emitted by a specific radionuclide. Okay, these are called tracers. So these tracers, they are introduced into the body, and then the images of these tracers are taken in a three-dimensional manner using a computerized software, basically. So these 3D images are the ones which we use for study. Okay. Yeah. So this would be a PET scan machine. Yeah. See that? Okay. Now, the next modality is a foot scan. Okay. Today, this modality also is a very cheap and easy modality. These days, it's becoming very popular because of the high incidence of diabetes all over the world. You know, where chronic diseases like diabetes, hypertension, and ischemic heart disease are constantly on the rise. So, diabetes and diabetic foot has become a very, very common existence today. So, this foot scan helps us to detect where all there are, where all there is peripheral neuropathy. See, diabetes affects the nerves, which cause sensations on our skin. And these sensations are taken away because of these nerves which are affected, and it causes a condition which is peripheral neuropathy, right? So this particular scan just helps us to, it's like a carpet. I don't know if I have a picture of it. So it's just like a carpet on the floor where you just walk across it and put your foot on it, and a scan is taken. Okay. So the scan looks like this, where you can see these red spots over here on the toe, on the second and third, metatarsals. So these areas indicate that, these are places where ulcers are likely to form. Sensations are less. Okay. There's some wound or some ulceration which has already started to form over there. This indication can be seen on the foot scan. Now, by coming to know that there is a likelihood of an ulcer there, we can be very careful, and the diabetic foot surgeon will advise you some kind of a specific footwear which can help to prevent those ulcers. Right? We get customized footwear also, which is customized exactly to suit one's foot. And by wearing those footwear, you can prevent these ulcers from coming up. So this is, although it's a very cheap modality, it's a very useful one. It's called foot pressure measurement system. Oh, sorry, there's a mistake here. Foot pressure measurement system. Okay. It's a non-invasive, painless technique. All it does is to detect the pressure points. So wherever the foot is under pressure too much, there is bound to be a little bit of ulceration or abrasion to the skin. Some injury is likely to happen. So constantly, if something is being rubbed against each other, then it will cause some damage to the skin. And then further, because these patients are diabetics, the ulcers, they don't heal very fast. So the foot ulcers, they become bigger and bigger. And then finally they become, a diabetic foot, which is a swollen condition, lot of inflammation, lot of pus inside, needs to be, sometimes the incision and drainage needs to be done. Sometimes the entire thing needs to be debrided. Sometimes the whole foot needs to be amputated, or maybe a finger, or whichever part is being, necrosed will need to be amputated. So it's a very bad condition to have. And this foot scan helps us to, prevents us from reaching that condition. It prevents the patients from reaching that condition of diabetic foot, or diabetic necrosis, foot ulcers and necrosis. It prevents us from going to that stage. Okay, it can be detected at this much early stage, where the pressure points itself are detected, and you know that there is peripheral neuropathy, right? Okay, so this is about it. Yeah. The next modality is an ultrasonography. Sorry, you need to excuse me for just 1 minute. Yeah, sorry. So the next modality is an ultrasonography. I think this is a very common modality. All of us know about it. There's nothing great about it. This is a machine which directly captures all the images in the form of ultrasonic waves. And these waves are signals are transformed into images. There are conducers. There are basically those probes, which are conducers, which um, are used to scan the internal structures, okay, like tendons, muscles, organs. It can capture fluid inside, blood inside cavities. Okay, all of that can be indicated on the scans. The one thing which I want to highlight more than the technology, I think technology has become very common now and everybody knows very well about the technology. What I would like to highlight is about the legal aspects around this technology. So we have an act in India, which is a PCP and DT Act, that is prenatal preconception diagnostic techniques. Okay, this act has become very stringent over the last few years, mainly because of the rising incidences of female feticide, right? The babies who are females are being killed in the womb itself. They're not allowed to be born. And this is very prevalent in certain regions of India more than other regions. There are pockets where, this is very, very high in incidence. So the government has come out with this act, and of course, it's a very old act, but now, over the last few years, it has become very, very stringent, to such an extent that a small documentary mistake can also lead to sealing of the machine, or it can even lead to cancellation of the registration of a particular radiologist, right? It has become so stringent. So the rules behind this PCPNDT Act are, number one, the history of every patient needs to be very clearly recorded in terms of how many children they've had in the past, which child is this. I mean, this is mainly for the obstetric scans, okay? We're not really worried about the other scans, as in other organs, the abdomen and thorax and all of that, cardiac scans. We're not very worried with that. But for the obstetric scans, we need to have the entire history of the woman, including her um, religion, her sex, her age, the number of issues she's had in the past, any obstetric history in terms of high risk or whatever. What is the reason why the scan has been done and all of that? So there are specific formats which are given to us by the government which needs to be followed and filled in. The second thing is that there needs to be a requisition. So anybody cannot come and do an obstetric scan without a requisition. So a doctor's prescription or a requisition note from the doctor is absolutely mandatory, which is also preserved by the hospital. While doing the scan, the doctor is definitely not allowed to disclose the sex of the baby to the parents. You can obviously see it in the second or third scans, the later second trimesters and so on. You can see the sex. You're not supposed to disclose it to the patients or the relatives. Um, we also have we also have to put up these boards uh, outside in the waiting lobby and inside within the sonography department, which reads very loud that this center does not do any kind of prenatal preconception testing, and it does not determine the sex of the child and does not declare the sex of the child. And if anybody is found doing that, they can be fined to the tune of whatever 50,000 rupees or so on. So that is a government ruling, and that government ruling is displayed very loudly outside and inside every sonography department. Besides this, the machine has a license. So the minute the machine is purchased and installed, it has to be used only after the license is in place. So it's a PCPNDT license, and this is given by the health department, the corporation, the municipal health department, and you're allowed to use the machine only after the license is there, because from the date of commencement of that license, every single scan which is done on the machine is tracked, recorded, intimated to the government. So that's the reason we don't use the machine until the date of commencement, which is mentioned on the license. So if any machine is put to use before the license is valid, the machine can be sealed. The other thing with this act is that the radiologists who do the scan also have to be registered along with the machine. So there are three things essentially which need to be registered while procuring the license. One is the machine itself with all the details, the technical details of the machine, the model number and the make and all of that. The second thing which needs to be registered is the radiologist. And the third thing is the location. So all these three things are mentioned on the license. So the machine, the doctor, and the location, they're all specific. So tomorrow, if you want to move this machine to another location and do the sonography there, it's not allowed, because this sonography is meant for that particular location which you have mentioned in your license, right? So all this is extremely stringent. Any slight deviation in this whole protocol will call for penalty of very huge amounts. Okay. What else? Yeah. So I've mentioned here, so this is PCP and DT, preconception, prenatal diagnostic technique. It also involves a monthly submission of reports online. Now, these days it's become a daily submission. It's like now daily submission of reports online. And it also involves a periodic inspection from the local authorities. So at any given point in time, they can come for a surprise visit. The local municipal authorities from the health department can just walk in for a surprise visit and can look at all your documents, will check the machine, will check the licenses, will check if the radiologists who are empaneled to the hospital on that license still exist with the hospital, or have they resigned and gone and somebody else is doing the scans. All this will be checked. Okay. The purpose why these documents are have become very important is, as I told you, to keep a track of the female feticide. So with these statistics, the government probably does its own analysis and studies to find out which religious groups or which caste, which creed, and which age group, and what kind of regions are more, prevalent, this sex determination is more prevalent in which of the regions and all of that. So it's basically for all this study and for a control of female feticide that this act is being implemented. Okay. So this is about sonography. Although this is not an imaging modality, it's a very important diagnostic tool, which is the stress test. That is or it's also called as a treadmill test. And I think it's a very popular cardiac diagnostic tool, because people love it. People love walking on a treadmill. So, you make people walk on the treadmill and look at their heart functioning on the screen. And we can find out abnormalities, arrhythmias, right? The patient's tolerance to exercise. All this can be identified. So these are the leads which are attached to the patient's chest. Patient is asked to walk for a minimum of about 15 minutes unless he cannot tolerate that stress and he stops in between. He should be able to walk for about 15 minutes. And there's a continuous cardiac monitoring that goes alongside on this monitor. And it determines all the preventricular beats and extrasystoles and abnormal rhythms and all of that. Okay. Yeah, so it basically compares the coronary circulation of the patient while at rest and while after physical exercise as well. There's also a nuclear stress test, which can be done, in which a radio tracer is injected before the stress test. And then during the test, the photographs of these coronary vessels are taken, and then it is compared with the ones before. Yeah. Besides this, I think ECG is something which everybody knows, which is also a diagnostic tool. A couple of tests which are used by neurologists, which are very important. Other than CT and MRI, these are the tests which a neurologist use on a day in, day out basis. So there are 2-3 tests. One of them is the EEG, the other one is the EMG, and the third one is an NCV. Okay. So EEG is basically a counterpart of ECG. ECG tries to study the cardiac activity of the heart, whereas the EEG tries to study the electrical activity of the brain. So that's basically the difference, right? Yeah. So this uses small, metallic discs, which are placed like this on the head of the patient. The brain cells which are there, they constantly generate these electrical impulses, and these electrical impulses, they produce graphs, just like an ECG graph. They produce an EEG graph or an EEG recording, and you can see the abnormal patterns of those electrical rhythms, just like we read the cardiac rhythms. You can read the electrical impulses and the rhythms of the brain as well. Very useful for diagnosing epilepsy and some other brain disorders. So this is just as common as an EEG for a cardiologist or for any other physician. Right? This is as common as that for a neurologist. The other test is an EMG, which is an electromyography. So an electromyography, myo is basically muscle, all right? And this electromyography, it evaluates the health conditions of the muscles and the nerve cells which control the muscles, okay? The nerve cells which control muscles, they are called as motor neurons. So these motor neurons, they basically transmit the impulses to the muscles, and the muscles respond, whether they should contract, whether they should relax, is the response of the muscles to those stimulation of those motor neurons. Okay. Now, this electromyography, it basically translates these stimulations into a graph kind of a pattern again. And those can help us to say whether the muscle is working properly, not working properly, and so on. Okay. So this EMG usually is done by doctors, but there are a lot many technicians who are now well trained in EMG and NCV. NCV generally the neurologist is always present alongside to tell which nerve to be tested, how to be tested, and all of that. Okay. I just wanted to give you a picture of this electromyography. So this is the machine, and this is how it looks. Yeah. Just a sec. Yeah. So this is an electromyography machine, and so if you can see here, it basically helps us to study whether these nerve cells are stimulating the muscles or not. So for different muscles, these signals will help us to basically detect their functioning or not. The third test which is useful to the neurologist is the nerve conduction velocity studies, okay, NCV. From the word itself, you can make out that it basically studies the conduction of the nerve impulse along the nerves. That's why it's called as nerve conduction velocity. The speed at which the nerve impulse is conducted, that speed or the velocity is studied in this test. Okay. And it helps us to detect if there is any kind of downstreaming, in terms of conduction. And it helps us to detect any signs of nerve injury. Okay, so the nerve here is electrically stimulated, and you try to track the conduction of the impulse. So that's why it's called as nerve conduction velocity. This test, as far as I can see in hospitals, is mostly done by the neurologists themselves because they want to, touch the exact nerve at the right spot without making a mistake. So they is generally done by them. Yeah. So these are three tests which I wanted to mention to you, which are useful for a neurologist. The last test which I want to talk about is a pulmonary function test. So a pulmonary function test is a test which is popular among the pulmonologists, right? Pulmonologists or the chest physicians, which are trying to diagnose and treat respiratory disorders like maybe COPDs, chronic obstructive pulmonary diseases, asthmas. Okay, these are ones which are trying to treat all of those. So such patients are made to undergo this PFT, which is a very, very simple tabletop test where a patient is just made to sit on a chair and blow into the mouthpiece, which is connected to a spirometer. So as they blow in, there are different parameters which are studied. I don't think I should be getting into these different parameters right now, but just to give you an idea, there is a tidal volume which we look at. Then there are some parameters which are called as post-expiratory volume, FEV, FVC. So all these volumes, they are detected basically to tell us whether it's the lung functioning is good or not. This test also helps us to differentiate between whether there is any kind of obstruction in the lungs or whether it's a restrictive lung disorder. it helps us to detect those as well. So this is how the machine looks. I've just put a picture of the machine as well as the report. Um, and this is again best reported by a physician or a pulmonologist. So this is the patient blowing into the mouthpiece, and then the graphs, they appear on the computer screen, and with the different measurements as well. So this is these are the measurements which you get: FVC, FEV1, FEV1, F1DC, MPV. So these are all different parameters which you get here, and these are all different graphical representations which can give you an idea about the capacity and the functioning of the lungs. So I think that's in brief about all the diagnostics. Excepting lab, I think I've taken you through most of the other important diagnostics. So we can go in for questions if you have any. Yes, any questions for me? I'll be happy to take them. No questions at all? All clear? Great. You can either unmute yourselves or you can put the questions on the chat box. No questions at all? All right. Okay then. So thank you for your patient hearing. Sarika ma'am?
Yes, ma'am. Students, if you have any query, you can unmute or you may write in the chat box. If you do not have, then ma'am can leave. Ma'am will wait for a minute and then we'll end the session. Yes.
Yes, yes. All right. I think students are dropping out now. Ma'am, I think there are no questions, so we'll wind up for today. Thank
Yes,
you
ma'am.
so much. Yeah.
Yes, ma'am. Yeah. Thank you, ma'am.